Good day. For this webinar, I will be presenting a case of a patient with varicella zoster infection. So this is the outline of the presentation. This is a case of patient EB, 23 years old female, married from Taguig and a full-time homemaker. Patient saw teleconsultation with a chief complaint of skin lesions. For the history of present illness, 2 days prior to consultation, patient had an onset of low-grade fever with maximum temperature of 38 degrees Celsius, associated with headache, body fatigue, and joint pains. No other associated symptoms. 1 day prior to consultation, noted eruption of skin lesions described as red small bumps on face, arms, and chest associated with itchiness. Patient now complains of sore throat. On the day of consultation, patient noted fluid-filled blisters and oropharyngeal ulcers associated with pain in swallowing, thus the consultation. For the past medical history, completed childhood immunization and has no comorbidities. Family history with hypertension on maternal side. Patient verbalized that few days prior to the skin eruption, she had an exposure to his brother who had the same skin lesions. So there's no food and drug allergies. These are the pertinent positive and negative. For the positive, the low-grade fever, body fatigue, headache, vesicular lesions, oropharyngeal ulcers. For the negative, the patient did not present dry cough and colds, conjunctivitis, abdominal pain, and retroorbital pain. These are the actual pictures sent by the patient during the teleconsultation. With the onset of low-grade fever and body malaise, skin lesions were subsequently noted evolving from red erythematous base, maculopapules, to vesicles, then appearing on the trunk and face, then rapidly evolving into other areas of the body. Lesions were also found on the mucosa of the pharynx. According to Harrison, the diagnosis of chickenpox is not difficult. The characteristic rash and a history of recent exposure should lead to a prompt diagnosis. Hence, my primary impression is varicella zoster infection or chickenpox. For the differential diagnosis, we can consider herpes zoster or shingles which is a sporadic disease that results from the reactivation of latent varicella zoster virus from dorsal root ganglia. Most patients with shingles have no history of recent exposure to other individuals with varicella zoster infection. We ruled out shingles since patients' lesions were generalized. Herpes zoster is characterized by a unilateral vesicular dermatomal eruption often associated with severe pain, which was not reported by the patient. Another ruling out is that herpes zoster, although occurs at all ages, the incidence is highest among individuals in the sixth decade of life and beyond. Second differential diagnosis is dengue, which begins after incubation period averaging 4 to 7 days. We rule in dengue since typical patient with dengue fever experiences sudden onset of fever, frontal headache, retroorbital pain, and back pain, along with severe myalgias, which was presented by the patient. These symptoms gave rise to the colloquial designation of dengue as break bone fever. Also, adenopathy and palatal vesicles were noted. We ruled out dengue since the appearance of the rashes in dengue are macular rashes to scattered petechiae, in comparison with the patient's case, which was described as fluid-filled vesicular rashes. In dengue fever, laboratory findings includes leukopenia, thrombocytopenia, and in many cases, elevation of serum aminotransferase concentrations. The diagnosis is made by IgM ELISA or paired serology during recovery or by antigen detection ELISA or RT-PCR during the acute phase. So the third differential diagnosis is measles. So symptoms of measles includes more than 3 days of high-grade fever and diffuse maculopapular rash. So there's a typical mucosal lesions in the mouth, which is considered diagnostic of measles infection in the setting of the typical rash and the fever. We ruled out measles since the three C's, that is a classical set of upper and lower respiratory tract infection in measles, are not present in the patient. So no cough, no coryza, and no conjunctivitis. For the primary impression, which is varicella zoster infection, age group of 16 years old to 25 years old are still susceptible in the Philippines. Commonly, this is observed during summer months. For the pathogenesis, there are three stages of varicella zoster infection, namely the infection stage, the primary viremia, and the secondary viremia. In the infection stage, varicella zoster is acquired through aerosol or direct contact. So there is inoculation of the virus in the respiratory mucosa, then replication in the regional nodes. For the primary viremia, there is replication in the liver and spleen and in the reticuloendothelial system. Secondary viremia, mononuclear cells transport virus to the skin and mucous membrane. Then the varicella zoster virus is released into the respiratory secretions and subsequently replication in the epidermal cells. The virus infects dorsal root ganglia during the chickenpox, where it remains latent until reactivation. For the clinical characteristics, humans are the only known reservoir for varicella zoster virus. Chickenpox is highly contagious with an attack rate of at least 90% among susceptible individuals. The incubation of chickenpox ranges from 10 to 21 days, but it is usually 14 to 17 days. So patients are infectious to 48 hours before the onset of the vesicular rash. So also during the period of vesicle formation, which generally lasts for 45 days, and patient is infectious until all vesicles are crusted. The hallmark of the infection are the skin lesions. So lesions are scattered rather than clustered, reflecting viremia spread to the skin, and they progress subsequently from rose-colored macules to papules, vesicles, pustules, and crusts. So lesions in all stages are usually present at the same time. So it begins on the head and spread rapidly to the trunk with relative sparing of the extremities. Diagnosis is clinical based on character of lesions and systemic symptoms. So these are the ways on which we can diagnose. Also, we can diagnose chicken pox. So Zank smear, which we can see multinucleated giant cells through direct fluorescent antibody tests, enzyme immunoassays, through DNA PCR, which is rapid and will confirm infection, and also viral culture, which provides a definitive diagnosis and can differentiate varicella zoster virus from herpes simplex virus. So for the complications of chickenpox, the most common infectious complication of varicella is secondary bacterial superinfection of the skin. So varicella pneumonia, which is the most serious complication following chickenpox, may occur in immune-compromised adult patients, particularly severe in pregnant women. Cerebellar ataxia and encephalitis are the most common neurologic complications. For the management plan, medical management of chickenpox in the normal host is directed towards the prevention of avoidable complications. So obviously, good hygiene includes daily bath and soaks. So acyclovir therapy is our oral antiviral. Also, pruritus can be decreased with topical dressing or the administration of antipruritic drugs, oral antihistamines. Antipyretics for fever, and we can also have oatmeal baths. Antibiotics may be given when there is a secondary bacterial infection. In neonatal varicella, we can give acyclovir 500 milligrams per meter squared every 8 hours for 10 days. For immune-compromised children, acyclovir 20 milligrams per kilograms orally 4 times a day for 5 days. In adults, those that we encounter regularly in teleconsultation, so though we can give acyclovir 800 milligrams orally 5 times a day for 7 days, or valacyclovir 1 gram 3 times a day for 5 days. In pregnancy, the same dose with adult, so we can give acyclovir 800 milligrams orally 5 times a day for 7 days. For the prevention, so there are three methods that are used for the prevention of varicella zoster infection. First is through immunization. So we can give live attenuated varicella vaccine. So second is the administration of varicella zoster immune globulin. And lastly is giving antiviral therapy, which can be given as a prophylaxis to individuals at high risk who are ineligible for vaccination and who are beyond the 96-hour window after direct contact. So for the first and second method, this will be discussed further in this table. So for the first dose in the immunization, we can give the first dose of the vaccine starting at the 12 months to 15 months. So at the age of 46 years old, second dose can already be given. But for your information, it can be given earlier. So it should have a 3 months interval from the first dose. So for those unvaccinated 7 to 12 years old, we can give two doses with um, with 3 months apart. Also for unvaccinated 13 years old above, two doses but should be 1 month apart. For those that have incomplete vaccination, we can give additional dose anytime at least 3 months from the first dose for those who are 7 to 12 years old. And for those who are 13 to 18 years old, one dose given at least 1 month from the first dose. So for the immunoglobulins, it should be given within 96 hours. So that's a post-exposure prophylaxis. So that's all for my report. So this is the reference. Thank you for listening.